Between Celebrex and all the other anti-inflammatories is it's just more specific. It targets the COX-2 receptor. Injections, a cortisone injection is going to be like a miracle to you. If you've got a really significant flare-up of arthritis in your knee, cortisone will be like a miracle. It's not a cure. I tell patients, you know, it's like having your house on fire and somebody comes off and just turns the alarm off. The fire's still going, but the alarm quit sounding. Cortisone doesn't grow cartilage back. It doesn't cure arthritis, but it simply helps take some of the symptoms away, the pain and the swelling. Unfortunately, those tend to come back, and then the question I get routinely is, can I have a cortisone injection every month? And the downside is that cortisone is actually bad for chondrocytes. It can inhibit chondrocyte or cartilage cell formation, and so repeated cortisone injections are a bad idea. But if you had a flare-up and you needed a cortisone shot, it will be a godsend to you. The other is this viscoelastic supplementation, Hyalga and Synvisc, and some of you have heard of it. It's the rooster comb, and it's really a lubricant that goes into the joint. I think what it does is it adheres to the remaining bone and cartilage and lubricates the joint. It's not a panacea. There are some patients it works very well in. Some patients it doesn't seem to help at all. And the hard part that I have as a physician is I can't predict that ahead of time. I do know that if someone has more severe arthritis radiographically, they're less likely to respond to the Synvisc or the Hyalga. Surgical options, I'm going to just go through these briefly because we'll talk a little bit more about this, but basically the analogy that I use is kind of like your car tire again. I'm stuck on these cars, but if you came to me and you had all 4 tires just worn out, I'd say get all 4 replaced. That's like a total knee replacement. If you came and said, I want all 4 tires replaced and only the right front tire was bad, it'd be foolish to sell you 4 brand new tires. You would probably want to just focus on the tire that's bad. And that's what a unicompartmental replacement is like, and that's what a patellofemoral replacement is like. And I'm not here to really go into a long discussion on that. I'm just here to tell you that there are more than one option besides total knee. Although when it boils down to it, total knee arthroplasty is the most common procedure done, and it's usually the correct one for most patients, and it's got excellent long-term results. There's a full replacement on the top film shown on your, let's see, that would be your left, and then the one on the right, you can see that this patient has a little bit of, or a significant amount of joint space narrowing in the inside part of the knee. So this is a full replacement, this is a partial. You can see we just replaced that side of the knee joint. This is white fluffy stuff, the bone cement. Obviously the metal's very dense, so you can see the metal prosthesis. And the piece here is the little plastic, medical grade plastic bearing that we use. It is a bone-sparing procedure. There are certain patients that it's absolutely indicated for, and if you're one of those people, it's a little less invasive, a little quicker recovery, and the long-term published results on unicompartmental replacement in the correct patient population is pretty good. So it's still an option. It is a technically more demanding procedure, but the 10-year results in the right patient population are actually equivalent to total knee replacement. Patellofemoral arthritis, this doesn't show very well, and I apologize, but the one thing I can show you is that's arthritis of the kneecap. It's very, very common, especially in women, especially women that are a little bit knock-kneed or were knock-kneed their whole life. And basically, if I can get this to project, on this film right here, on the sunrise view, what we're looking at is the kneecap relative to the femur. That's called a merchant view, where we basically just shoot right across the kneecap. And basically what you can see is that the cartilage underneath the kneecap is just about worn out there. And then this is what a patellofemoral replacement looks like. I won't go into much detail on this other than in the right patient, this is also a good operation. But total knee replacement is really the gold standard of care for knee arthritis. It's got excellent 15 to 20-year data. Obviously, we're getting into a little bit of a newer era where we're operating on younger patients, people getting arthritis in their late 50s and early 60s. And so I think we're putting more demand on our knee replacements now. And it calls for us as design surgeons to design implants that can withstand that. People don't want to just, walk the dog until they're 85. They want to be out, mountain biking. They want to hike. They want to water ski. They want to snow ski. They want to play golf. They want to go bowling. And so we need to have joint replacements that will work well into a patient's 90s and function very well. And that's really part of the area that I'm very interested in research is looking at that normal knee function and those the normal motions of the knee, and see if we can replicate that more fully with knee replacement. It's not a bionic knee, and I'm going to just talk a little bit about our program here. We have an integrated therapy program. Physical therapy, if you're the best surgeon in the world and your patient does not perform physical therapy correctly, they will not get a good result. Likewise, you can have the best therapist in the world, and if you don't do the surgery correctly, your patient won't have a good result. So it's kind of a partnership between us and the therapist working with the patient, and it's critical. And I think some of the patients that you'll hear today will attest to that. There are some complications. The most common is blood clots, and something I worry about every day. One of the things that we're doing now is we're getting patients up earlier and earlier. If you have your surgery in the morning, the people I operated on this morning, they've walked this afternoon. So you're not an invalid. We get you up out of bed quickly. And all of those things may sound mean, but they actually really reduce our complication rate. But blood clots are our biggest issue, and we go through great lengths. We've got little devices. You wear these special little stockings while you're in the hospital for the first 6 weeks. We have these mechanical foot pump devices that help reduce the incidence of blood clots, and we put patients on blood thinners. And it's something that we have to manage, but that's one of the issues. The second big issue that I worry about is infection, and obviously staph infection is something that is just around. We're going to all have to deal with it. We've gotten a good thing here at St. Thomas. We actually have 4 rooms that are identified for joint replacement that our group uses, so that we don't have to worry about the case before the one we operate being a ruptured appendix or a diabetic foot wound. We're just in these ultra-sterile rooms with just joint replacement. We have our own staff that work with us day in and day out, so having that team approach has, I think, been the best thing for me and the best thing for my patients in our group and our group's patients. Is having those staff that work with us every day, I think, really minimizes our post-operative complications and our infection risk. And I would be willing to put my record up against anybody's and St. Thomas's record on infection rate. I think if you look at the health grades rating, we got that 5-star rating, and a big part of that is related to our low complications. Long term, we worry about implant loosening and something called osteolysis. I won't go into detail, but that's part of the follow-up that Dr. Christie was talking to you about. It's very important for us to follow our patients. One of the things that we have is that makes things better these days. We take these digital x-rays and we have digital templates. We can know exactly what size your bone is and what size of implant to use. And this is actually in the operating room. And I don't know if it shows very well, but there's the aqua little template of the knee replacement. This is a side view of a knee, so you can see the kneecap, and you can see this little aqua knee replacement, and that's actually sized for that patient. And so we've got that up in our office, and that transfers down to the operating room. It's tremendous. It's really helped make us better surgeons. As I was mentioning during the surgical procedure, we use a nerve block now, like a dentist will numb up your tooth, we'll numb your leg. The anesthesiologist does this before surgery, and so it makes the post-op recovery tremendous. Post-op, walk the same day as surgery. You'll plan to do physical therapy for 6 to 8 weeks. This is an intra-op look at a knee replacement. This is what it looks like. It's kind of shiny metal. The top part's made of cobalt chrome. The bottom part's either made of cobalt chrome or titanium, and then the little medical-grade plastic inserts, that white thing that you see there. So in conclusion, finally, treatment of knee arthritis should be based on the severity and location of the degenerative joint disease, and your doctor is going to be best to help you guide through that. I think it's something I like, and I know my partners are the same way. I like to sit down and pull the x-ray up with the patients in the office and show you what we're seeing, so you know that the decisions that we're making together. And then again, Total Knee has demonstrated excellent long-term pain relief and improved function for patients with severe arthritis. And I tell patients, You know, knee replacement done properly works very well. And the same way with hip replacement. And that's all I got. Thank you.